Now we'll be discussing about the vocal nodule. Now, first of all, there are various names of vocal nodule. It can be called as a singer's nodule or a vendor's nodule or a teacher's nodule. Now, if you see the profession of all the three, they need to raise their voice. So, there is a prolonged periods of voice abuse which is happening. So, write down beta, the etiology of vocal nodule is the prolonged period of the voice abuse, and it occurs at the junction also. Again, this is a star question. It occurs at the junction of anterior 1/3 and posterior 2/3. So, first of all, the etiology is because of the prolonged voice abuse, and it occurs at the junction. The site is, it occurs at the junction of anterior 1/3 and posterior 2/3 of two vocal cord. The reason why it is occurring at this junction is because this is the junction which is having a maximum vibratory area. So, at the area of maximum vibratory area, this vocal nodule they occur, and they are always symmetrical. So, they are bilateral and they are symmetrical. This is also an important question. They are bilaterally symmetrical, and they are sessile. Sessile means that they don't have a peduncle. So, they are sessile. What are the clinical features? If you see what are the clinical features of the patient who present to you with the vocal nodule in the OPD is that the patient will be having hoarse voice and the patient will be having a voice fatigue. So, hoarse voice and voice fatigue are the clinical features with which the patient will be presenting to you in the OPD. Now, coming to the treatment, treatment is that you give such patient speech therapy, and if they are not improved by speech therapy, then you go for the microlaryngeal surgery. Microlaryngeal surgery is also known as MLS. So, you go for microlaryngeal surgery. So, basically the treatment, it depends whether the patient is having early or the premature nodules. If they are early nodules, you go for speech therapy, and if they are late nodules or they are formed nodules, you go for MLS, that is the microlaryngeal surgery. Now, this is the picture which is depicting the vocal nodules, and if you can see here, these are the vocal nodules and they are bilaterally symmetrical. Always remember that this condition, it occurs at the junction. It is occurring at the junction of anterior 1/3 and posterior 2/3. So, this is the area of maximum vibratory surface, and they are bilateral, they are symmetrical, and they are sessile. If you see at the other image also, this is the other image, and you can see this is the epiglottis. This is the epiglottis part, and you can see the bilateral sessile vocal nodule. So, they are symmetrical. If you can see in this image, they are symmetrical, they are bilateral, sessile, and they are not pedunculated. So, you can see here they are the bilateral vocal nodules. So, what is the treatment of vocal nodule? If they are present in the early phase, then you go for speech therapy. If they are presenting to you in when they are formed, they are mature, and you can go for microlaryngeal surgery. Microlaryngeal surgery is performed in the microscope. That's why it is known as the microlaryngeal surgery. Now, coming to the other condition of the vocal polyp, that is of the vocal cords, which are oftenly asked in the exam, is the vocal polyp. In vocal polyp, apart from the cause, site, and the chief complaint, they are the same for the, as we have seen in the vocal nodule, and this also occurs at the junction of anterior 1/3 and posterior 2/3. So, apart from that, the vocal polyp is not because of the prolonged voice abuse. They are present when the patient shouts suddenly. So, a sudden voice abuse like shouting, which is patient is going on a unprepared larynx. suppose if someone has snatched a purse from a person, and if a person shouts suddenly, scream, save me, or patient is asking for a help. So patient basically is asking, is raising the pitch of the voice without any preparedness. So in our unprepared larynx, when the patient is shouting suddenly, a brief spell, it is not prolonged. So a brief sudden voice abuse, it can lead to vocal polyp, and it also occurs at the junction of the anterior 1/3 and the posterior 2/3 of the true vocal cord. And the cause, site and the chief complaint, they are the same as we are seeing in the vocal nodule. The only difference is that it is unilateral. If you see the vocal nodules, they were bilateral, but this condition is unilateral. It is unilateral, and the vocal polyp is pedunculated. Now, since it is unilateral and it is pedunculated, that means the other vocal cord is fine. So the vocal, both the vocal, two vocal cords, they will be vibrating at a different pitch. So that's why we will see a diplophonia. Very important. Please note down, my dear friends, that diplophonia is a characteristic feature of the vocal polyp and not vocal nodule. So what is the treatment? The treatment part is that you go for the speech therapy and you performed a microlaryngeal surgery. And believe me, we are doing surgeries day in and day out, and this microlaryngeal surgery, it is a very rewarding surgery, because the patient will present to you, the chief complaints will be diplophonia, will be hoarseness, and as soon as you remove this polyp by microlaryngeal surgery, the voice of the patient will be fine, and microlaryngeal surgery should be followed by speech therapy, and the patient will be absolutely fine. Now if you see this image, you can see here, you can see this is the vocal polyp, this is the vocal polyp, and this is occurring at the level of, at the junction of anterior 1/3 and the posterior 2/3. And what is the characteristic? That it is pedunculated. It is not sessile, it is pedunculated, it is unilateral, and it causes diplophonia. So rest all are same as the vocal nodule, but these are the only three differences, that is it is pedunculated, it is unilateral, and the patient will be having a diplophonia. Now how we will be removing them? So now this is the image. In this, the surgeon, basically this is the surgeon who is using this is the operating microscope. So surgeon is removing the polyp with the help of operating microscope, and you can see this is the procedure which is undergoing, and this procedure is known as MLS or microlaryngeal surgery. Now what about the vocal length when we are performing a surgery in a microscope? Now the vocal length of various ENT surgeries are different. For example, if we are going for an ear surgery, we will be using a focal length of around 200 millimeter, and if we are doing anything in the nose, we will be going with a focal length of 300 millimeter. That is the difference between the lens and the patient will be 300 millimeter. And if you are going for the larynx, it is maximum in the larynx, it will be 400 millimeter. Now my dear friends, there is a very good hack to remember this, that you should remember this as ENT, that is ear, nose and throat, and 2, 3 and 4. So ear is 2, nose is 3 and larynx is 4. So 200 millimeter, 300 millimeter and 400 millimeter. So this is a very good trick to remember what kind of lens we are using for different ENT surgeries.